Good evening, everyone. So I'm going to present today the two interesting cases of monocular elevation deficit. So the purpose is to present these two different cases. Case 1 was an 11-year-old girl who presented with a downward deviation of right eye since birth. The best corrected visual acuity in this eye was 20/800 and the left eye was normal, that is 20/20. The Hirschberg test showed marked hypotropia. You can see in this picture that the right eye shows marked hypotropia. Even on Hirschberg, you can see it is more than 45 degrees of hypotropia with the limitation and elevation in the right eye of -3 to -4. Ocular motility and eye was normal in the left eye. Modified Krimsky's test showed more than 50% diopter of hypotropia in the right eye, and rest of all examination, intraocular examination, slit lamp, pupil and fundus examination was normal in this child. So you can see that in the central picture, the patient shows hypotropia, and in elevation, there is marked limitation of elevation in the picture. A provisional diagnosis of monocular elevation deficit of right eye was made, and neurological imaging was done, which was found to be normal. Force reduction test was done, in which inferior rectus was found to be tight. Hence, a staged procedure of inferior rectus followed by an augmented NAPS procedure was planned for this patient. So post IR recession, there was no change in hypotropia. The patient remained the same in the primary gaze. However, there was slight improvement in the elevation of the right eye. Then the second surgery, that is augmented NAPS, was done. That is transposition of the horizontal recti to the adjacent to the superior rectus, preserving the spiral of Tilloch's. Augmented, that is the standard NAPS, and augmented NAPS means posterior fixation suture was placed in the sclera 8 mm posterior to the insertion of the superior rectus, and the lateral borders and the medial borders of the superior rectus was hitched with the transposed horizontal recti muscles. So this is after the augmented NAPS. This is a post-op day 3 picture, the first picture. Second is the post-op 3-month picture. In primary gaze, patient is maintaining a good orthophoria, and there is improvement in elevation also. Second case is a 7-year-old girl who presented with drooping of upper lid of the right eye since birth. In this case, the patient did not have amblyopia. As we see that the first case, the child had amblyopia. This case, the best corrected visual acuity in the right eye was 20/30, in the left eye was 20/20. Hirschberg test showed hypotropia along with marked limitation and elevation in the right eye. The ocular motility of left eye was normal. The prism bar cover test showed 60 PD of hypotropia in the right eye, along with mild exophoria. The Bell's phenomenon was poor. Since she had ptosis also, there was Marcus gun phenomenon present, and rest all examination was normal. So you can see that the first picture, right upper lid severe ptosis is seen along with hypotropia, and also note the unmasked component of pseudotosis when the right eye is made to fix. So this is the child in primary gaze showing hypotropia of around 60 PD, 30 degrees is seen on Hirschberg, and a limitation of upgaze. So monocular elevation deficit with severe ptosis of the right eye along with pseudotosis component with poor Bell's and MGP. Neuroimaging was normal. FDT was found to be tight for inferior rectus, and a surgical plan of. In the previous case, we did a staged procedure. In this, we did a single sitting procedure, that is inferior rectus recession, along with a modified Nishida's procedure to correct the ocular alignment, and then a second stage procedure for managing the ptosis. So modified Nishida's procedure, in this a radial conjunctival incision is made in the supratemporal and the supranasal quadrant, and a non-absorbable polyester suture is woven through the superior 1/3 of the horizontal rectus muscles, 10 mm behind the insertion. The same suture is placed through a scleral bite, which is 12 mm behind the limbus in the midway between the superior rectus and the horizontal recti. The suture bite then transposes the horizontal recti and forces superiorly. So these are the intra pictures of the modified Nishida's procedure. So post Squint surgery, the patient look at the primary gaze picture. The patient is maintaining orthophoria with improvement in the ocular motility in elevation. So this is after the second surgery, that is also ptosis correction, which we did by doing a silicone rod sling surgery. So the patient had a residual hypotrophy around 8 PD, and the exophoria still remain with a good ptosis correction. So these are the first case. Look at the pre and post-op picture, and this is the second case. So this treatment of MED can be variable, but the treatment of choice depends upon whether the FDT for IR is tight or is free. If the IR is tight, it needs to be recessed. depending upon what procedure you need to do, you will, depending upon the amount of hypertropia, so it is whether
Let's move to the conclusion slide.
Ma'am, just this is the last, almost the last
This
slide.
is the last slide?
Yes,
ma'am. This is the conclusion slide?
This is the last slide, next slide. So we, according to the amount of hypertrophy, we plan the procedure. These are the two procedures which we have discussed for large angle of hypertropia. So when you have a large angle of hypertropia, you can decide whether if you have a tight IR, and you can go with two-stage procedure. If it is large angle more than 60 PD, then you can do a two-stage procedure. If it is less than 60 PD, you can do a single-stage procedure. So advantage of modified Nishida is that you can do an IR recession along in the same sitting as the modified Nishida's procedure, and it is reversible also. So these are two good options for large angle monocular elevation deficit. Thank you.
Did you find any difficulty with near vision?
After doing the surgery, sir? Sir, no, my first patient was amblyopic.
First case.
No, sir, no problem with near vision. No problem. So actually the child was already amblyopic, so she was not appreciating much with the right eye. So her vision, she did not complain about any problem.
The picture was showing there is disparity between one and
Slight exophoria post-surgery because of probably the imbalance between the recti muscles, horizontal recti.